Hi, this is Brian Kim. I want to share with you case number 172 in the Best Way to Do Cataract Surgery series. This is a patient with a really small pupil, but also a dense lens, so I decided to put in iris hooks. And you're going to see my technique and how I place my iris hooks. I like to do it in a pentagon shape, putting one in the subincisional episclera, and I'll show you how I place the hooks and then take them out. And you're going to see careful mechanical fracturing. In this case, I'm actually using the hybrid tip, which has that polymer material. I'm not really a fan of that. But this is, again, an older case illustrating just the general concepts of mechanical fracturing. And again, I'll be able to reduce CDE as well as minimize zonular stress. So I use my corneal mark to help me center incisor-rhexis, and I go ahead and make my incisions. I make my paracentesis incision for both my cataract incisions as well as my hook incisions. So on the iris side, again, I just place it at the limbus for the iris hooks, the 4. But then you saw in the beginning, I have an episcleral incision that I make, and it's going to go right underneath my main incision. So again, it looks a little bit complicated, but I'm making 5 incisions for the iris hooks and then 2 incisions for my paracentesis. So I'm injecting intracameral lidocaine and epinephrine. And so you can see the maneuver of placing the iris hook. I'm holding it perpendicular to the hook, getting it around the iris edge, holding it, and then cinching it down. And it's important to get this concept of twirling. So again, you see it didn't come on there, so I go ahead and release it and then twirl. You need to twirl, and sometimes you have to use a stopper to twirl so that the hook points down. So again, a lot of this is happening a little bit quickly. So again, I'm holding it perpendicular, sliding it down. You have to make sure that the stopper's up enough in order to do that. Twirl it down and then cinching it down. So I'm going after the subincisional here. It's a little bit tricky sometimes, can get caught in conjunctiva. I'm pulling the stopper back, turning the stopper down, and then hooking the iris, and then cinching it down. Again, hold it perpendicular, slide it in. You can rotate your hand just like I did there to engage the pupillary edge, and then pull the stopper down. So I want to show this again in slow motion. You can see I'm holding it perpendicular with the forceps, and you saw that was a pro move. I went in and then I just hooked it because it already was pointed down, and then I used my left hand to cinch down the stopper. So let's see how I do it with the second one. Again, you want to hold it and approach it perpendicular. This gives you maximal control. So again, I'm holding the perpendicular, going in, and then I'm trying to hook it, but then you saw I had to kind of let go. I'm going to use the left hand to hold the hook, but then you see I used my right hand to twirl the stopper down. Hold the hook, hooking the iris, lifting it, and cinching the pupil, and then I'm pushing down with the stopper with my right hand. So again, that even in slow motion, it went pretty fast. So you see the first one didn't actually hold, so I grab it proximally on the hook, lift the stopper with the other hand, and then redirect and engage the pupillary edge with the right hand, hooking the pupil with the hook, holding it in position and retracting it, and then pushing the stopper down. If you don't hook and tent it up, it's like having a fish on a line. You need to hold tension so that hook stays in place in the fish's mouth. If you release it, if it's a non-barbed fishing hook, then it's going to release the fish. So it's the same concept. You want to hook the pupil. In order to do that, you have to hold tension. Okay, again, the concept is the same like when you have a fish on your line. So I'm using my right hand to control the hook and the left hand to twirl the stopper. Now the hook is facing down. I use the left hand to lift and then hooking the pupillary edge, hooking it and retracting it so it holds cinch down with my right hand and then pushing the stopper down with my left hand. So now I'm going to go after the subincisional one. It's the same idea, but again, you can get caught in conjunctiva and there's blood, so you just have to be mindful of that. You just go ahead and slide it in. I'm cinching the stopper back a little bit because it's too far forward. Using my right hand, again, holding. So I'm advancing with my left hand, pushing the hook, using the right hand to twirl and making sure that the hook is engaged on the pupillary edge, retract with my right hand, hooking that pupil again like a fishing line. You want to hold tension, and then I slid the stopper down with my left hand. So again, I'm holding this last hook perpendicular on the stopper here, making sure I approach it nice and flat, flatten it out. And here I'm trying to do it all in one move, and I did it. Okay, good. So that's because I held the stopper and I was able to rotate my wrist subtly in order to engage that pupillary edge. You want to, again, retract with the right hand. Make sure you get that hook around the pupillary edge, again, like a fishing line. You want to keep that fishing line taut when you've hooked that fish in the mouth. And so I fill the eye with some viscoelastic, and then this is going to be my triplanar corneal incision. I did make one mistake. I normally make my main incision before I put that subincisional iris hook there. I don't really want my diamond blade to, get dinged up by that hook. And so I would have made my incision first before I put that hook in. But everything went fine. Now go ahead and puncture the center. Again, these are the older Haldi per cars. These are not the sharp tip ones. Again, the older case. I punctured the center, pull down, and then grabbing the right side of the tear, going around circumferentially. Again, using the corneal mark that I made, which will hopefully give me a well-centered and sized rhexis. You can see this is a fairly dense lens. Use that iris hook to control the iris as well as retract the subincisional pupil, because you don't want that to cause the iris to start to come out of your wound. And so this gives you exquisite control. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, decompress on the left side, and then the lens begins to spin by hooking the peripheral lens on the right side. Just removing some bubbles there. So again, like I said, this is a polymer tip. Irrigate the surface of the eye. Lift the incision with the chopper going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, I place the chopper underneath the rhexis edge, sliding it, go vertical, and then tilting the figurative vertically subincisionally, bringing the instruments together, and it fractures the lens in half, making the chopper flat, sliding it under the rhexis edge under the right side, hooking the peripheral lens, pulling it centrally toward the figurative, and then fracturing the right heminucleus, that is the cross chop. Lifting that first quadrant up, and then using the instruments to mash the lens into smaller pieces and then emulsifying the lens. So this is a technique in slow motion. Again, I have my hand pronated, leading off with the tip of the chopper, sliding it underneath the rhexis edge and turning it vertically. And then the figure tip is tilted vertically as well into the subincisional space, bringing the instruments together, crushing the lens completely in half, and then I'm able to divide the lens completely here. Pronating my hand again for the chopper, sliding it underneath the right heminucleus, underneath the rhexis edge, turning it vertical, hooking the peripheral lens, and then pulling it towards the phaco tip, crushing the lens in half again. In that case, the phaco tip is acting like a chopping block because you crush the lens against it. Lifting that first quadrant up with some vacuum and then crushing the lens because I have the chopper around the lens and then crushing it in half, and then doing the same thing, grabbing it with a little bit of vacuum with the phaco, getting the chopper around the lens and then crushing it once again. So again, successive crushing movements, crushing forces to mash the piece into smaller and smaller pieces, and then once the pieces are small enough, go ahead and emulsify the lens. So again, this is a ultrasonic energy sparing technique. I still need ultrasonic energy, but I try to use it as little as possible. So I lift that second fragment up with the chopper, and once it's out of the bag, I mash it into smaller pieces and then emulsify it. Get the chopper around that second quadrant, same maneuver with the cross chop, bring it towards the phaco tip, which is now deeply positioned in the bag, fracture it in half. You can see that sudden loss of resistance. Lifting that piece up with some vacuum and then crushing it in half and then emulsifying it. Using the chopper to loosen up that one piece, grabbing it with a little bit of vacuum, getting around it and crushing it with the instruments, and then emulsifying the lens piece. rotating the second heminucleus in front of me, placing the chopper around the lens equator, pulling it centrally towards the phaco tip. You saw it didn't get quite around it, and you can feel when it's not around it. See, you saw that. I did that twice now. Now I hooked it. So that's the difference. It's again, like I say, when it's like fishing, when you feel like you have a fish on the line versus not, you'll see it kind of moves funny if you haven't effectively hooked it. And so that third attempt, it did hook it, and then I was able to crush the lens. Get that chopper around that last piece, pulling it up, and then crushing it with the instruments, and then emulsifying the lens piece. So again, a fairly dense lens, got it all out, removed the epinuclear material, making sure you eat all those small remnants. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. It's a fairly clean bag, but there is some Cortex there. I start to go after it little by little. Switch to polish mode, polishing underneath the Rhexis edge. Polishing the posterior capsule as well. Pulsing into the subincisional Capsulorhexis, which you start to see some stuff coming out. So that's the thing, unless you check, you don't know. There's no way I would have known if there was anything deep in the fornix because you can't see it. But I loosened it up, I'll be able to go after it some more again with the sweeper. So push some more cohesive viscoelastic to fill the bag. And again, you can see how old this case is. This is the old sweep that I'm using. So again, old sweep, hybrid tip, which I don't normally use, and then also the old Haldey-Perkar forceps. Super old case. So I'm going to widen the incision. Again, this is a case with a small pupil as well as a dense lens, and usually in my mind that could be a sign of zonulopathy. So I like to go with the 3-piece lens. Have the bevel facing to the left. Let the leading haptic go into the bag. Rotate your hand counterclockwise to let the optic come out flat. Let the trailing haptic come out of the eye, and then dial the trailing haptic into the bag. So again, this is a removal technique. With the two-headed technique, pull the stopper down, holding the hook proximally, again, nudging the stopper so it twirls. And then once you pull, you want to pull it 90 degrees, and then it comes out. Rotate it 90 degrees, and then it comes out. So again, release the stopper, making sure it disengages the iris, pupillary edge, turn it 90 degrees. And you want the tip of the hook to be pointed down. So when you do it that way, there's only one way to rotate it 90 degrees. So if the open end is facing to the right, you want to rotate it 90 degrees to the right, like I did there in that last one. So again, I go underneath the lens, removing all the viscoelastic from within the bag. Polishing underneath the Rhexis edge. Making sure I get that. There's some cortical material still in the subincisional area. We'll make sure I get after that here in just a second. Using the Maltzman to try to reposition the haptics like the way I want it to be. Good. Yeah, with those lenses, because they're stiffer, sometimes they'll sit a little wonky in the capsular bag, and you just have to rotate it so that it sits better and better centered. So we're going to remove all the viscoelastic from within the bag and the anterior chamber, and then I'll hydromet my incision. So again, this is a dense lens. You saw I did a iris hook placement in a pentagon shape, and I like to put a subincisional episcleral hook as well. You saw my technique in sliding it in and pulling it out. Again, you do it this way so that you can reuse these hooks. They can be expensive, and there's no reason to just break them or damage them. You don't want to just yank it out. You will damage the hook if you do that. It's a very well-controlled technique of doing iris hooks. Again, I don't like to use rings personally. I can use it, and it works fine. But there's always chances that things can happen with those contraptions. With iris hooks, you have exquisite control. You can titrate the amount of tightness. And it's also an excellent skill to learn when you're doing dislocated lenses and other types of techniques when you want to be able to localize your iris retraction when you're doing the surgery. So again, this was also showing double chop, cross chop mechanical fracturing, efficiently disassembling this lens, which was fairly dense, lifting pieces up out of the bag, fracturing the lens pieces into smaller pieces. You saw the CDE was fairly low considering the density of the lens. Put a 3-piece lens in for more zonular support, and that was the end of the case, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.